Welcome, everyone, and thank you for joining us today for this Lunch and Learn webinar. We are so glad that you're here and grateful to this panel of experts who will explain and shed light on this very important component of cancer care. This is the first of a series of 3 webinars that will focus on different aspects of clinical trials and precision medicine for patients with rare cancers. The next 2 webinars will take place in September and December, so please watch our website and social media for more information. I'm Kristen Palma, the president of TargetCancer Foundation. My late husband, Paul Poth, founded TargetCancer when he was diagnosed with a rare cancer, cholangiocarcinoma, in 2007. He was only 38 years old and a new dad, and was shocked to learn that someone so young and healthy, living in Boston with the best research and medical minds, could be told that there was no treatment meant for his disease and little research being done to find a treatment just because it was rare. He started TargetCancer Foundation to change this, and almost 15 years later, we have given over $2 million in research grants, including over $1 million for cholangiocarcinoma research, a disease that now has multiple identified actionable mutations that have led to treatments, exactly what Paul had hoped for. At the time he was diagnosed, precision medicine and genomic profiling were just beginning to be used. Now, they are critical components for rare cancer care. This is what led us to our most exciting initiative in 2020, when TargetCancer Foundation designed and operationalized TCF-001 TRACK, a first of its kind precision medicine clinical trial that is enrolling 400 patients with rare cancers. This trial allows patients to consent remotely from their homes with no requirement to travel. Once enrolled, we facilitate genomic testing of blood and tissue at no cost to patients through our partnership with Foundation Medicine, a team of world-renowned rare cancer experts who comprise our virtual molecular tumor board, then review the results and provide personalized treatment recommendations. We have already enrolled over 140 patients from 37 states with 40 different rare cancers and are so proud to lead this important work. Both of our panelists today are members of our molecular tumor board, and we are so grateful to them for sharing their expertise and knowledge every week for TRACK patients, and today for all of us. Finally, I'm honored to introduce our moderator, Mary Pat Lancelotta. Mary Pat has been a board member at TargetCancer Foundation for 6 years and was one of our earliest guides in developing TRACK. Mary Pat is the Vice President of Corporate Marketing and Communications at Adaptive Biotechnologies. She's a seasoned healthcare strategist with a passion for precision medicine and brings over 20 years of business and strategy experience. We are so grateful to have her leadership on our board and thank her for leading this conversation today.
Great. Hello, everybody, and thank you to Kristen and TargetCancer Foundation for hosting this this talk on this extremely important topic. Anyone who's faced a cancer diagnosis themselves or has been through that journey with a family member or close friend knows how overwhelming the experience can be. There's so many decisions to make: which doctors to see, whether to get a second opinion, which therapies to consider and why, and many, many others. And patients and caregivers often go through a crash course in both the US healthcare system and biology at the same time. There are many choices for diagnostic testing that can make a major difference in a patient's treatment pathway, and often gives them more information about how the cancer came about to begin with, which can be informative both for them as well as their family members. But of all of the decisions to make, diagnostics is probably the most complicated and the one that's most underappreciated by patients, and I would argue physicians alike. Many of the newer tests that Kristen mentioned that really can make a huge impact on a patient's care and what options are available to them have yet to be fully integrated into the standard of care, despite overwhelming amounts of data. And patients really need to be their own advocates. So we'll talk a bit about that today. But for all of those reasons, I'm thrilled to have the opportunity to be here today with Julia Elvin and Catherine Skefos to learn more about genomic and genetic testing and how patients and caregivers can access and use this critical information that these tests can provide in their treatment journey. I'd like to start off by having each of the panelists introduce themselves. I'll just first hand it to Julia, who is the SVP of Pathology and Diagnostic Medicine at Foundation Medicine. If you could just give us a bit of your background and some color on your expertise on the topic, that would be great. Thanks, Julia.
Thank you so much, Mary Pat and Kristen and the TargetCancer Foundation for hosting, I think, this really important webinar on what I think is a confusing topic to patients and physicians alike. My name is Julia Elvin. As Mary Pat said, I am the Senior Vice President of Pathology and Diagnostic Medicine at Foundation Medicine, which is a tumor testing genomic profiling company based in Cambridge, Massachusetts. I am my background is I am an MD PhD with a PhD in human and molecular genetics from the Houston area, Baylor College of Medicine, and came to Boston to pursue my pathology residency and fellowship at Brigham and Women's Hospital. I practiced diagnostic pathology for 8 years before joining Foundation Medicine in 2014 and have been here at the laboratory pursuing my dream of bringing biologically and molecularly guided diagnostic information to patients across the US and across the world for the last nearly 10 years. Let me hand it over to Catherine.
Sure. Thank you, Dr. Elvin, and thank you all for being here today for this, this Lunch and Learn webinar. So I am a certified genetic counselor. I work at MD Anderson, where I provide genetic counseling primarily for patients in the endocrine center, but also patients with a wide variety of different cancer diagnoses, from pediatric to adult. I also work with family members of patients who have been diagnosed with cancer who want to learn more about their potential for hereditary risk of cancer. Before coming to MD Anderson, I was a genetic counselor at Dana-Farber Cancer Institute and Boston Children's Hospital in Boston, where again, I provided genetic counseling for patients of all ages and with all different types of cancer diagnoses. I have a master's degree in genetic counseling from the University of Alabama at Birmingham, and prior to that, got a master's degree in medical anthropology from the University of South Florida. My research in that realm focused on healthcare access and health disparities, so that's also a passion of mine. I really have a special interest in teaching, especially teaching other healthcare providers about the value of genetic testing, and of course, talking with patients about how genetic testing can potentially help them as well.
Great, thanks to both of you. So I'm going to start this off with one fundamental question. So genetic and genomic sound very similar. And I think even people who are in the industry, in the clinic, may be confused about what those types of testing are. So can you talk about the two different types of testing that are available and how they differ? First, I'll hand it over to Julia. Can you talk about what is genomic testing and what are the various applications?
Thanks, Mary Pat. So I agree. The words sound a lot the same, and they come from actually the similar Latin root, where genetic testing is more focused and genomic testing is looking at the DNA that encodes for basically the instructions for all of our cells, but across every gene that is in the cancer cell. So genomic testing is really looking at multiple genes at the same time to understand how many changes put together result in the biology of what's going on in that patient's tumor. And this approach has really emerged in just the last 10 to 15 years with the advent of sequencing technologies that allow us to look across multiple genes at the same time, as well as the databases that have emerged from all of the research and also testing that have been going on to help us understand what changes that we might see in these many, many genes are actually functional, called driver mutations, as opposed to passenger mutations, changes that have come along but are really along for the ride. and are not what are marking the biology of the tumors. Genomic testing has typically been applied to either tumor tissue directly, either fresh or fixed paraffin-embedded archival tissue that is generated routinely in any biopsy or surgical procedure, or more recently has been applied to indirect access to the tumor genome via cell-free DNA collection and technologies from a blood draw from the patient's peripheral circulation. I'll pause there and hand it over to Catherine.
Speaking of blood draws, no. So genetic testing, which we can also call germline testing, is testing that's usually done either through a blood sample or a saliva sample. And for people who can't provide either of those, we can also do a cheek swab. So this testing is looking at the genetic information that a person was born with, rather than genetic changes that accumulate over time within a cancer cell, which is what Julia was referring to. So when we look at the genetic information that someone was born with, we can assume that for the most part, they inherited that genetic information from their mom or from their dad, and have the potential of passing it on to future generations. So that's another difference between the type of genetic testing that I do and the type of genomic testing that Julia does. So when it comes to the germline testing, we're really focusing on perhaps why did this cancer happen in the first place? Was this person born with a risk that caused it to happen in the first place? And second, do they have a risk of developing another type of related cancer in the future? And third, do their relatives have a higher chance of developing certain types of cancers?
And Catherine, can you talk a little bit about why and when somebody who's been diagnosed with cancer may want to think about germline testing, and what types of decisions or actions can they or their family members take with the information that they can get?
Absolutely. So the question of why comes, or why someone might want to do this, is to find answers to those things that I just mentioned. Why did this cancer happen? Do I have a risk of developing another one in the future? And do my family members have a risk? Now, the when a patient may elect to have this done can differ very widely between patients. Sometimes a patient may be referred to genetic counseling or for genetic testing right away at the time of their diagnosis. That could be to help inform things like surgical decisions. So a good example of that is if a woman is diagnosed with breast cancer, her physician may want her to think about genetic testing early in that diagnostic process to help decide, is a lumpectomy sufficient, or should we consider a broader surgery if there is that genetic or hereditary risk at play? Now, even if someone's surgeon wants them to have that testing done, genetic or germline testing is always optional when it comes down to it. Sometimes if someone has a new diagnosis of cancer, they may feel overwhelmed, and perhaps the last thing they want to think about is if they have another risk of cancer in the future, or whether their relatives may be at risk. On the other hand, sometimes that's the primary question that people have as soon as they're diagnosed. Why did this happen, and what can I do to keep this from happening to my loved ones? So really, this is why my field is called genetic counseling. We help patients understand, based on their own feelings about this, based on their experiences, where they are in their diagnostic process. Is now the right time to have this testing? And if not, when might make a little bit more sense? Does it make more sense to have it right after some type of surgery, so that they feel like, okay, I've done what I needed to do in the immediate time. Now I have the bandwidth to think about this other testing.
Great. So, on both counts, I want to refer back to something that Julia mentioned, which is that, a lot of these tests have really, come about and evolved over the last, decade or so. And, one thing that I know a lot of patients hear from their physicians when they talk about testing, if they even know to talk about testing, is whether or not tests are actionable, and how that might dictate whether or not the physician is likely to offer or even willing to order the test at the request of the patient. So, Julia, starting with you, because I think foundation medicine has really been along for this ride. Can you talk about how cancer treatments and diagnostics have evolved, within that time frame, and why that makes it so important that patients are aware of this testing now?
Yeah, so, it's interesting. When I first trained as a pathologist, I was trained to look at the pattern under the microscope that the tumor cells were making and understand which organ system in the body was likely the place where the tumor started, and maybe observe a few other features. And this is how we would name the tumor. So a patient would have a low-grade breast cancer or a non-small cell lung carcinoma. And this, while it captured some elements that were relevant to the biology of the patient's cancer, it clearly was not sufficient to divide patients up into groups where we understood more about the biology and why those cells from that particular organ decided to stop cooperating and, what I say is, go rogue and start making a tumor. And through the process of being able to look initially at a handful of genes that had been discovered in the research labs through directed molecular testing, like single gene tests, but then over time with the ability to look at multiple genes across all tumor types, what we started to realize was that within certain tumor types that might look or be named the same historically, such as non-small cell lung cancer, we have multiple different molecular diseases. So now the lung cancer grouping is divided up into EGFR positive or ALK fusion positive, RET, ROS fusion driven lung cancers, as opposed to being lumped all together under the umbrella of non-small cell carcinoma. And what this has done is it has allowed physicians, it's allowed us to understand the biology of these diseases and then try out new drugs specifically, either specifically on patient populations where this molecular information gives us like some biological rationale why that particular drug might work in that patient, or to look at drugs that do perform well in a particular tumor subtype and figure out which groups are more likely to respond so that we can better predict and match therapies going forward in the future. On the flip side, what we have found as we are looking at genes across tumor types in more of a broad and open-minded way is that we've identified tumors that never would have been grouped together and never thought of to be treated with the same therapy, but molecularly they're similar to one another. And one example is microsatellite unstable or MSI high tumors. Colon cancer, a large proportion of colon cancer and a large proportion of endometrial cancer actually have this molecular phenotype. And what has recently been recognized is that if you know that molecular subset in those two very different tumors, the same drug may be effective for those tumors, despite them coming from different organ systems.
Julia, one of the things that I think has been really interesting to watch over the last, 10, 15 years has been, I would say back in 2010, when you had patient advocate groups, they were very much along the lines of breast cancer and lung cancer and colon cancer. And I just at ASCO a couple of weeks ago, there was a slide that was presented that had over a dozen different patient advocate groups that were called things like N-Trackers and Met Crusaders and ROS1ers that were all really aligned around this genomic grouping. So I find it to be really, fascinating how the patient community has started, picking up on this as well.
And I would imagine that that also helps in a lot of different ways within the patient community, with folks being able to share their experiences more around the journey that they're going on and the types of therapies that they are being given, and other opportunities. So they may find more commonalities and ways to exchange tips and advice and support for one another, rather than some of the more traditional organ-based support groups. And there's probably room for both. Actually, everybody can use as much support as possible, I think,
Right.
in this domain.
Right. Speaking of how the technologies have evolved, Catherine, one of the things I'd like to talk with you about, this came up in several conversations, around breast cancer and BRCA testing. I've heard so many times when somebody said, oh, somebody who's had breast cancer 15 years ago, or, oh, I got BRCA tested to get BRCA testing. Whereas in fact, I have heard about people being retested and then lo and behold, they're positive when they thought they were negative. Can you talk a little bit about that and what patients need to be aware of in terms of, timing of testing or whether it makes sense to get repeat testing?
Absolutely. This is such an important conversation to have with patients and for providers to sort of check in on their patients' previous testing. And just like you said, Mary Pat, not say, oh, check mark, they had the genetic testing done. Our technologies are constantly changing, not only in our ability to do the testing, but also in our ability to interpret the results. We've had the ability to test our whole genome or sequence our whole genome for years and years now, but we have not always known how to interpret that or what is relevant to which patients. And so those BRCA genes are a great example. If someone had testing 10 or 15 years ago for, let's use breast or ovarian cancer as an example, then their testing likely did only include 2 genes, BRCA1 and BRCA2. And now we know of a whole handful of genes that can be associated with hereditary breast or ovarian cancer risk, and other genes that may very well be relevant to the individual based on their family history that may have nothing to do with breast and ovarian cancer. So these days we tend to do what's called panel testing, where we look at multiple different genes associated with the cancer types that are seen in the individual or in the family to determine if they were born with any changes in any of those genes. And so I recommend for patients that if they had their testing 5 or 10 years ago or more, check in with your doctor. The worst they can say is you've had all the testing that is recommended at this time. But in a different scenario, they may say, yeah, you're right. Your testing is not considered comprehensive by today's standards. So let's update that for you and see if there's anything new that we can tell you about.
So, I want to send this question to Julia, but I want to highlight something that was brought up by somebody in the audience who had stage 4 MSI high stage 4 appendix cancer and is currently being treated with an immunotherapy. So first of all, that's amazing that you had the opportunity to get that testing, because as you mentioned, without that testing, you wouldn't have known about that as a potential therapeutic option. And, Julia will know the sort of data better, but I think 5 years ago, you may have had the same testing that gave you the same result, but the results and the response to immunotherapy wouldn't have been something that was known. So in that regard, Julia, can you talk about, how you might guide patients to think about timing around the testing that they get, as well as, I think there's kind of 2 things. It's one, the tests advance and the knowledge of cancer biology advances. On the other hand, as Catherine mentioned, the actionability and what we know, how to do advances. So can you talk about how patients might navigate that in terms of timing or reinterpretation of testing?
Yes. Well, so first of all, I just have to say it is so exciting to hear, and I'm so glad that the testing has been able to occur in the audience member who has this very rare tumor type. So appendiceal cancer is so uncommon that it is unlikely that a separate appendiceal cancer trial looking at immunotherapy would have independently been undertaken, or if it was, it would have taken a really long time to recruit enough patients willing to participate in a clinical trial with this rare cancer. But what our audience member has brought forward is the idea that the results and the advances in therapies that apply to a more common cancer type with a shared molecular finding, when you find that in a rare tumor, it can unlock access to therapies that really have a high chance of working. And I really hope they are for our audience member. To that point, and to Mary Pat's point, when we first started testing at Foundation Medicine, and actually just a couple of years ago, there likely would have been really a focus of therapy addressing MSI high status only in selected tumors, possibly only in colon cancer, maybe colon and endometrial cancer. But because of the approach that some of the pharmaceutical companies have taken, and also our regulatory agency, a shout out to the Food and Drug Administration. I think that, they need a few props sometimes too. They have been really, forward-looking in taking the evidence and saying if multiple patients across many tumor types with the same molecular feature respond, then we don't have to have individual trials for every rare tumor. And instead, we will grant a pan-tumor approval for a particular drug when the molecular alteration is present. And so this is something that in the case of microsatellite instability only happened within the last couple of years. So tumor testing that had been performed before that may have uncovered the microsatellite instability, but the report may not have indicated, or the physician getting that report at the time may not have been aware that immunotherapy could be an option for that finding. And so similar to germline genetic testing, genomic test results should be looked at every decision point. Previous results should be looked at every decision point and re-examined for advances that may actually have emerged for your alterations. One of the things that some laboratories do will actually be able to help and refresh the kinds of clinical interpretation that go along with those findings. Similarly to germline testing, sometimes genes with mutations will be detected, but the function will not be known for that particular mutation. And then over time, the science will catch up and we'll actually learn more. And those mutations may also move from an unknown function category into a known function category in the somatic space too. And so that also is another reason to, not, put that molecular report in a drawer, but continually have it as a live piece of data that you go back to and you think about when you're making decisions about next steps in your care.
So Julia, along those lines, another question that's come in from the audience, is there any research that's being done for cancers that don't currently have a lot of actionability from, from genomic or genetic testing, such as sarcomas?
Sure. So, for example, sarcomas is a great example. This is, it's a big umbrella term, meaning a tumor derived from the cells that make connective tissue, basically, mesenchymal cells. And this is a really diverse group of tumors. So one of the big challenges actually in diagnostic pathology with sarcomas was that the patterns never were very informative necessarily about the biology. So over time, specific diagnostic types of mutations have been identified that allow us to put a specific name and understand the natural history of these sarcomas. And then once we start having the ability to group and identify patients with tumors that are similar to each other biologically, then this opens the door to not only being able to test targeted therapies that might be specific to some of these, for example, fusions, such as NTRK fusions driving some rare sarcomas, but it also helps us to go back and re-examine the success of more conventional therapies. So there may be certain groups that that had better responses to certain types of chemotherapy or radiation therapy, or whose natural history recurrence time would be different, but it was shrouded, it was obscured by the lack of really good categorization. And now we can go back and re-examine some of that literature and maybe find things that were discarded as treatment options, but that might actually work for a subset of patients, in addition to this allowing more targeted therapies to be developed to some of these more specific driver fusions.
Okay, and another question, and this one to Catherine. Have we uncovered all of the various genetic mutations that cause cancer?
We have certainly not, and I think that Julia would back me up on that one. From a germline perspective, I can say that every week I'm meeting with patients where we look at their family history and we say, there's a lot more cancer than we would expect to find in a family, even if there's some sort of environmental component, even if maybe there's other explanations at play, and their genetic testing comes back completely normal. And we say, is that because these truly are all happening by chance, or is there a genetic factor there that we just haven't uncovered yet? And I think a big element of where we'll go in the future with finding out about this is learning about those gene and environment interactions and finding those, quote, smaller genetic components that somehow interact with our environment, interact with our diet, our lifestyle, things like that, to influence cancer, to make it where we do see cancer happening more often in certain families that at this moment we can't explain.
So speaking of cancers, that are hereditary in families, one of the questions that came in ahead of the webinar was around Lynch syndrome. So the question was, if family members have the same mutation, and sometimes they're siblings and very closely related, why is it that they get different cancers?
This is $1 million question, because we also can see families just like what you described, where one patient develops multiple related cancers. Maybe they have a colon and an endometrial and a stomach cancer. And another sibling who has the same exact mutation can live until age 80 and never develop cancer. And we don't know why. And that's the worst answer ever, I know. But again, we think there might be some type of protective factors, protective genetic factors that we don't know how to identify yet, or there may be additional risk-related factors in a person's genetics that we don't know how to test for yet. But the other answer to that is, as Julia was saying earlier, cancer is often an accumulation of multiple different mutations within that cell that cause it to go haywire. And because of that, that means that there are some mutations that one mutation in the case of Lynch syndrome that the person was born with, and then they have to accumulate that other mutation over the course of their life. So something is leading certain people to develop that second mutation in some parts of their body and not others. Something is protecting others from not developing that second mutation, or once they do, their body shuts that down some other way. So we have a lot to learn. That's the short answer, is we have a lot to learn.
So, there was a similar question on, do we yet understand the entire universe of cancer-related genes, the ones that are mutated that actually drive the cancer? I know what Julia is going to say in answer to that, but so certainly we're continuing to learn all the time, but can you talk about what are some of the efforts and how patients can actually participate in efforts to better understand what those genes mean and what therapies might work for them?
Yes, so I think there's a lot to learn about the inherited components for cancer predispositions or cancer protective, genes or types of elements that might be modifying cancer risk. I mean, I would point out that there are also folks that have no inherited cancer risk, but despite a lot of mutagenic exposures, miraculously don't get some of the cancers that we come to expect, associated with UV damage, skin cancers, or possibly smoking related cancers. So there is an interplay within our bodies between repair mechanisms for the genomic damage that happens in each cell and surveillance to eliminate kind of the initial stages of renegade cells developing. I would say the additional piece is that genomic testing is just the start. And I know that lots of us feel pretty overwhelmed with just the genetic and genomic information. But what we have to also recognize is that within each cell, that DNA is used in different ways to, make RNA that tells the cells which proteins to make. And there are additional layers of controls that stack on top of the actual DNA coding sequence. So I would say that we probably have some things to learn about additional genes where mutations are significant to cause cancer. There's probably something to be understood around the combination of mutations that by themselves don't cause the cancer, but just, kind of unluckily, the combination leads to an oncogenic state. And then the complexity on top of that is a mutation that changes the regulation of a gene, turning it up or down, but that is not encoded in the DNA directly, is something that we're still going to need to explore. So from a participation standpoint, I think that, patients, there are a lot of options to participate in clinical trials, not just ones that test drugs, but also ones that are registry trials that allow folks to contact you and follow up to understand better some of these variants of unknown significance. And this has really helped in the germline space. I'll hand it over to Catherine because I think it's much more well developed in that space.
Yeah, we have a few different options for patients who want to be involved in this progress, if you will, of figuring out what these things mean, whether it's an uncertain result that someone got on a genetic test, or whether their test came back completely normal, but it's still, you know, that family history or personal history is suspicious for some type of predisposition. One example I can give is I work with a lot of patients who have rare tumors called paragangliomas and pheochromocytomas. And with those patients, there's a wonderful trial registry that I can refer patients to that is taking place in San Antonio, where they're actually doing what's called gene discovery. They are taking patients' genetic information and that of their family members and trying to find what else could be at play that we don't know about yet. And so I think that asking your doctor about those types of trials too, or what we call natural history trials, where this is what Julia was referring to, where we can really track things over time to see, okay, who with this mutation did develop a tumor, who didn't? Can we figure out why? All of those things require patients to seek them out and participate in those types of things so that our knowledge can grow over time.
You know, earlier in the discussion, we talked a little bit about how adoption of some of these tests tend to lag a bit, you know, even among physicians. So, you know, how might patients stay informed about their options and really advocate for themselves if they, you know, to first of all, make sure that they have the opportunity to take the testing that could potentially help them, but also how to talk to their doctor in a way that helps them get what they're looking for?
That is such a great question, and I absolutely agree that patients advocating for themselves is really important. And there's a number of different, I think, areas to become educated on in order to advocate effectively. So there is the broad question, which is, has my tumor had any kind of molecular characterization, period? Or was the diagnosis made solely by traditional means? And that can get you to that first branch point of whether molecular information was incorporated at all into the diagnosis and the thoughts about your treatment plan. The techniques that maybe are employed vary, though, from institution to institution and lab to lab. So sometimes a patient will be told that, yes, molecular testing was done and we didn't find anything. And I encourage every patient to say, okay, well, print me out a copy of the report. And these are the things to look for. So sometimes there's molecular testing that is done that is sort of the bare minimum standard of care at that moment in time, but it's really limited. So a number of years ago, a patient would have been considered, you know, tested, molecularly characterized if they had a lung cancer and got just an EGFR and an ALK test. And if both of those were negative and the patient was told there's nothing, we found nothing, they could still have one of those ROS or RET or HER2 or BRAF or tumor mutation burden high or MSI tumors that just was not even tested for. So testing has to, you know, you have to advocate for some testing. And then if you're told that testing has been performed, get a copy of the report. Look at the extent of testing. Ask the question of your physician, is the type of test that has been done looking for all of the things that are in the NCCN guidelines for molecular characterization as a first step. And then the other thing that I think even goes a layer deeper that even most oncologists don't appreciate is that even if you test for a particular gene, the method that you use to test for that may not detect all of the different ways that gene might be disrupted. So a test that just looks at substitutions of single nucleotides might pick up all of those if they were present in the gene, but if there is a rearrangement causing a fusion or an amplification or a complete loss of the gene, will not be detected. So it's not just about the comprehensiveness of the genes that were tested, but also the approach that allows you to know if all the categories of alterations would have been detected. And now over time, we've even learned that there's these broad genomic signatures that can help us identify therapeutic options that are even bigger than the genes themselves, that require us to look at, for example, aggregate numbers of mutations or the presence of scarring that's indicative of loss of double-strand break repair, such as what happens with the BRCA functional loss. So I guess the take home here is, getting a copy of the report, asking the question about the comprehensiveness, making sure the copy of the report isn't just the note in the chart, but actually comes from the laboratory that performed the test. And if you can always call the laboratory that performed the test, and they should be able to provide you not just with your results, but the actual test composition and characteristics, and the things about that you want to know about the test too, such as analytical sensitivity and specificity. And all of those things go into knowing whether that testing was valid and comprehensive. And then always feel free. I always tell patients that people get second opinions when they're talking about which surgeon's going to operate or which oncologist might be treating them. But getting a second opinion for your pathology and your molecular pathology is also possible and very, very valuable. So somebody in the molecular pathology space or diagnostic medicine space can also help interpret those particular reports that you will then have in hand. That was a very long answer, but I'm very passionate about this, Mary Pat.
I am too, Julia, and I wanted to add from a germline perspective, I have many of the same recommendations. If your provider says that genetic testing, germline testing isn't indicated for you, that very well may be the case, but it never does hurt to, like Julia said, ask for a second opinion, ask to talk with a genetic counselor if you are concerned about your family history of cancer. We know that there are some types of cancers that are almost never hereditary, as far as we know, and some that usually are. And there's a big spectrum between that. And we have guidelines to help guide that. But certainly don't hesitate to ask to speak with a genetic counselor. Also, there's a common misconception that, and Mary Pat, this may have been on your list to talk about later, but I just want to put in a plug. A common misconception that if someone has had comprehensive genomic testing of the tumor that did not show anything, the misconception is that then they do not need germline testing, and that is not true. These are two separate tests designed for very different purposes. And a study came out last year showing that in some genes, up to almost 20% of mutations can be missed. 20% of germline mutations can be missed when just sequencing the tumor. So even though genomic testing of the tumor is an extremely powerful tool, it just wasn't meant to pick up these germline mutations. So again, if there's any concern from a family history perspective or a diagnosis perspective for a germline mutation, don't hesitate to specifically request that information.
One of the questions that had come in ahead of time is, what if you do have both genomic testing and genetic testing and somehow there's a mismatch in the results, or the results don't seem to agree? Can you comment on what you do in that scenario?
That's a really good question, and I think it gets at the point that I was going to dovetail with Catherine to say that tumor genomic testing picks up both the acquired somatic mutations, but it also can detect many of the background germline mutations. but there are types of genes that are assessed in germline testing that may not be assessed or not be considered as relevant for somatic testing. So a lack of an overlap between the actual things that were tested for can cause discrepancies between the two reports. And then also, another possibility for discrepancies between the tumor and germline testing can be around the functional level of evidence to suggest that it is of known significance. So there are genes of known significance in the hereditary space that might be of unknown significance when it comes to tumor biology. So for instance, it conveys an elevated risk of developing cancer, but we don't actually know what it does on a cell-by-cell basis to contribute to the biology of that cancer. So those are a couple of particular reasons why there might be discrepancies, as well as we're testing different, different samples altogether. So the performance characteristics of the tests, and also, sometimes the tumors get so mutated or so abnormal, and they lose chromosomes and they lose areas of their genome, it's possible that the underlying genetic alteration could be obliterated or covered up in those cases. Catherine, other thoughts about discrepancies between germline and somatic test results?
Yeah, so I would just add that each report should be valued as a standalone element of your care. So just because the mutation is on a germline report but not a tumor report does not invalidate either. They are certainly, for their own purposes, equally as accurate and valuable for all of the reasons that Julia mentioned.
Great. One other question that has come up. We've talked a lot about how patients need to advocate for themselves. What are some things that are being done to increase adoption among the clinical community, of both of these types of tests, but also, further advancements like liquid biopsies and other kind of newer diagnostic tests?
Well, I think that I want to give a huge props to TargetCancer Foundation and for the advocacy groups that are out there helping to educate patients and clinicians. I would say that the clinical trial that Kristen described at the beginning of the webinar is an incredibly forward-looking approach to allowing patients with rare tumors where just the utility of genomic testing and genetic testing may not be easily looked up, in the literature, and being able to tap into expert colleagues, which is what happens in the TRACK trial, to both get testing performed and also to get support from folks who have been in the precision medicine space for a long time, dealing with rare tumors, to take a look at those results and provide recommendations around next steps.
Great. And I know we only have a few minutes left, so any final key takeaways from either of you?
Go ahead, Catherine.
I think my key takeaway would be that advocacy for yourself as a patient is key in this realm, but also I want to acknowledge that that is really difficult. Healthcare providers have a hard time distinguishing between the types of testing that we have been discussing today. And so I want to emphasize for the patients and for the healthcare providers on this call today that you should not be afraid to ask for help in interpreting this information. And don't stop until you find an answer. I think that you should not regardless of what field you work in or your level of expertise in that specific field, we can't all be an expert on everything. And so it's important to draw on the expertise of others when there is confusion about your treatment plan or what you're recommending for a patient or whatever the case may be.
And I will second that and also say that for physicians, you have a pathology department wherever you are. And pathologists, they were historically known as the doctor's doctor. So tap in to the folks in your hospital who may be a little bit more familiar with different diagnostics and lean on them and ask them to show up, ask the questions in the case discussions that happen during tumor boards. And then also recognize that there are resources even beyond that. So at our laboratory, we have a team of more than 25 pathologists that are on staff with expertise in molecular pathology who are on call. We have an on-call service to assist providers who get the molecular results and to help them interpret it and get the most use out of it. And that's also open for patients as well. And so, and most pathology departments and other laboratories have similar types of, or should have similar types of resources to help you interpret the results that they are giving out. So ask for the help.
Great. Well, we're running up on time, so I really want to thank Julia and Catherine for an incredibly enlightening discussion. As I mentioned, this is a topic that is near and dear to my heart and so important for patients to be aware. In that vein, I believe that Target Cancer Foundation is going to be sending some resources to people who attended the webinar that kind of along the lines of how to ask questions of your doctor and then how to be that advocate for yourself or for your loved one. So please be on the lookout for that. And I just want to thank everybody for all of the time that you spent with us today. And once again, thank you to Julia and Catherine and Target Cancer Foundation for hosting this very important webinar.
Thank you, Mary Pat.
Thank you.
Have a great afternoon, everyone.